All right, party people, we are back at it with another one. Let's get it. If I was to give you an 80-year-old female with a 2-month history of dry cough, some shortness of breath, she'd been smoking for over 60 years. Her cardiac maximum impulse is at the subxiphoid space. She also has a 3 out of 6 holosystolic murmur at the left sternal border. And I give you the following radiograph. I then present you with these option choices. I also inform you that her holosystolic murmur increases with inspiration. She also has a loud S2. Now, of the option choices, which would you pick? All right, this is how we're going to tackle this question. So first and foremost, the point of maximal impulse is located at the subxiphoid space. You have to know this as being for COPD. Now let's look at the chest x-ray. So what we're seeing here is hyperinflated lungs. This is due to air trapping as well as due to a flattened diaphragm. This is classic for COPD. You have to be able to recognize large lungs when you see them. Basically noticing big black lung field and a narrowed cardiac silhouette that's been pushed towards the midline. If you look, it's almost as if the lungs are squeezing the heart medially behind that sternum. Now, this is in contrast to something like congestive heart failure, where you typically see large lateralized cardiac silhouette. That's basically where the heart looks way larger than it should. It's dilated or hypertrophied. Either way, it's not tucked behind that sternum, it's pushed way over to the left lung field, pushed towards anatomical left, aka the right side of the image. But here the heart is slim and centralized. This is COPD. You need to know this. When they say point of maximal impulse as being in the subxiphoid space, that means beneath the xiphy-sternum. This supports the diagnosis of COPD. Sometimes they'll even give you a description of saying the cardiac silhouette looks long and narrow without a chest x-ray at all. And you still have to know that that's COPD. Now you have this 3 out of 6 holosystolic murmur that's along that left sternal border. That's accentuated with inspiration. You have to know that that's tricuspid regurg. Now normally, yes, a holosystolic murmur is typically associated with mitral regurg, but right-sided murmurs like tricuspid regurg get louder with inspiration. Another point that you need to memorize. You have to know this. Why does this happen? It's because when you inspire, the diaphragm moves downward, intrathoracic pressure drops, venous return to the right atrium increases, and volume increases, accentuating that right-sided murmur. You need to really know these 2 points. So first, inspiration increases right-sided murmur. Second, expiration increases left-sided murmur. If you're able to logically work through these, that's great. If you forget, you have to be able to memorize these. At a minimum, you have to memorize these. It would be much better though if you understood why this is taking place. And as we said, as you inspire, the diaphragm moves downward. Intrathoracic pressure drops, venous return to the right heart increases, and that increased blood volume will increase and accentuate the right-sided murmur. Now dealing with the loud pulmonic component of S2, a loud P2. That's very important because it indicates pulmonary hypertension. That's another point you need to memorize. S2 is the sound of semilunar valves closing, aortic and pulmonic. It's split into A2, the aortic, and P2, the pulmonic. Normally, A2 comes before P2. There are many types of S2 splitting, such as widened, paradoxical, but just for now, let's just deal with a loud P2 means pulmonary hypertension. This is due to pulmonic valve slamming shut against increased pressure in the pulmonary vasculature. You might be wondering, why is there tricuspid regurg in a question about pulmonary hypertension? You have to be able to link that the most common presentation of tricuspid regurg on USMLE is pulmonary hypertension or cor pulmonale. There's a few cases that you need to know for tricuspid regurg. Number 1 is IV drug use. This would be involving tricuspid endocarditis. You could also have to know carcinoid syndrome. This is a right-sided valve lesion. Now dealing with cor pulmonale, this is a right-sided heart failure due to a pulmonary cause like COPD, cystic fibrosis, pulmonary fibrosis as caused by Crest syndrome. There's a bunch of things that can cause it. Just understand that the whole concept is that you have pulmonary problems that eventually lead to right-sided heart failure. Now, a key diagnostic requirement for cor pulmonale is that pulmonary capillary wedge pressure, PCWP, aka meaning the left atrial pressure, needs to be normal. And you might be asking, why must this be the case? And the answer is because the most common cause of right heart failure is left heart failure. So to diagnose cor pulmonale, the left heart must be normal and not failing. Otherwise, it cannot be cor pulmonale. You need to also remember that left heart failure plus right heart failure is congestive heart failure. Now let's go through the other answer choices to see what is in fact correct. When I gave you decreased left ventricular compliance, this is wrong because what we have is a right heart problem, aka cor pulmonale, and the left side is not involved. Next up, we have decreased right ventricular compliance. This is also incorrect. While it sounds plausible, it implies primary stiffness of the right ventricle. For example, in amyloidosis, you might find this. But this is not a secondary strain from pulmonary disease. Our issue is pressure overload from the lungs, not intrinsic stiffness of the ventricle. Moving on to decreased alveolar capillary beds, this is correct, so let's break it down. In COPD, specifically the emphysematous component, you lose alveolar septa. That means you have a loss of surface area for gas exchange and loss of capillary beds embedded in those septa. The pulmonary vasculature is a parallel circuit, and resistance in parallel circuit is reduced by the number of available pathways. If you lose capillary beds, you increase the total pulmonary vascular resistance, which in turn leads to increased afterload of that right ventricle. You'll have pulmonary hypertension, as well as right ventricular hypertrophy and failure. This is cor pulmonale. So, decreased alveolar capillary beds is the mechanism for cor pulmonale. They especially like to test this on your licensing exams. Now, another mechanism they test is hypoxic vasoconstriction. This is more related to chronic bronchitis, more so than emphysema. In chronic bronchitis, the blue bloater, hypoxia causes vasoconstriction, which increases pulmonary pressure, and in turn, you'll get that right-sided heart strain. So again, just to recap this, emphysema is a loss of capillary bed with increased resistance. Chronic bronchitis, you'll have hypoxia followed by vasoconstriction. This is then followed by increased resistance. Either way, the right ventricle faces more pressure, resulting in cor pulmonale. All right, as far as primary pulmonary hypertension, this is incorrect. This is a genetic condition, usually due to BMPR2. It shows up in younger, non-smoking adults, not in elderly smokers. So they'll give you a woman in her 30s that is suffering from this. It can also cause a loud P2 or tricuspid regurg, but it's idiopathic and not associated with COPD. As far as pulmonic valvular incompetence secondary to lung disease, this is incorrect because incompetence here would refer to pulmonic regurg, which is not what's described. Pulmonic regurg is a diastolic murmur, not a holosystolic one, for starters. Also, pulmonic regurg is extremely rare on USMLE. Not that that is enough to exclude it, but you also have to know that tricuspid regurg is the murmur associated with pulmonary hypertension and cor pulmonale, not pulmonic regurg. Let's spin the block one time to make sure that we drive this home. With decreased alveolar capillary beds, this patient has cor pulmonale. This is secondary to COPD, and that's the correct pathophysiological mechanism here. All right, that's it for this one. Go crush it.